Today's topic is psoriasis, a very important papulosquamous disorder for your exam point of view. What is psoriasis? Psoriasis is a chronic and recurrent inflammatory skin condition with variable clinical heterogeneity affecting nearly 2% of the world population. It is a papulosquamous disorder. Not only it affects the skin, but it can also affecting the scalp, nail, joints also. So, this is the definition is the most important, that it is a recurrent inflammatory skin disease with considerable clinical heterogeneity affecting approximately 2% of the world population. So, psoriasis is a multifactorial disease. It is a multifactorial disease. The exact pathogenesis is not known, but the disease occurred due to the complex interaction between the genetic, environmental and the immunological factor. The genetic, environmental and the immunological factors all plays a very crucial role in the development of the disease. The skin injury and the streptococcal infections are well-known environmental triggers. Skin injury and the streptococcal infections are well-known environmental triggers. Now coming to the age of onset. Usually the psoriasis can affect in any age group from the neonatal period to 8 decade of the life, but the two peaks has been seen as the age of onset is concerned. First of all, the mean age is 23 to 37 years, two distinct peaks with possible genetic association. Early onset disease, the disease occurs between the 16 to 22 years of age group or before the 40 years of age group. The disease is in this case the more severe and extensive and more likely to have the affected first degree family members with the disease. The early onset disease is most associated with the most commonly HLA-CW6, and in this case the disease is more extensive and more likely affected the first degree family members. Late onset disease is usually occurs after the age of 50 years and it usually found between the 57 to 60 years commonly, and the disease in that age group is comparatively milder and affecting the first degree family members are nearly absent. This is very important. Affected first degree family members are nearly absent, and in that case the HLA-CW6 association is less commonly seen. So, the disease can occur in any age group from the neonatal period to 8 decade of the life, but two peaks has been seen. One is before 40 years, that is between the 20 to 30 years, and another peak is seen after the 50 years. And the nearly 75% of cases of the disease occurs before the age of 50 years. Nearly 75% of the cases occur before the age of 40 years, This is very important. Now coming to the genetic influence. So, psoriasis is a polygenic disease, As far as the genetic influence is concerned, the several studies have been found. The studies of the monozygotic twins shows the concordance for the disease, that is in 64% found in a Danish study. So, several large studies have been performed. In a large German study shows when both parents are affected, the chance of development of the disease is nearly 41%. But when one parent is affected, chance of development is near about 14%. So, there is a genetic association is found. And the most important, multiple susceptibility locus has been identified, and the SORA1 gene, PSORS1 gene at the chromosome, short arm of the chromosome 6 was the first gene discovered in relation to the disease. This is very important. The SORA1 gene at the chromosome 6p21 was the first gene discovered in relation to the disease. Now, the disease expression, the disease can occur in association with both genetic as well as the environmental factor. So, several genes have been implicated. It is a polygenic disease, but the most important gene which you have to remember is the SORA1 gene, that is PSORS1 gene, which is found in the short arm of the chromosome 6, is the most common gene which is identified in the psoriasis. Now coming to the common triggering factors. So, what are the common triggering factors of the disease? There are some triggering factors of disease which can exacerbate the disease. Most important is the infection, that is the streptococcal infection and the viral infection, number one. Number two is the skin trauma. What is skin trauma? It is also known as the Koebner phenomenon. That means the psoriasis lesion developed along the line of trauma or along the line of injury. This is known as the isomorphic phenomenon or Koebner phenomenon, which is found in the disease. Now coming to the psychological stress. Stress also exacerbates the disease. So, stress is a very important factor. Some medication like antihypertensive drug, beta blocker, ACE inhibitors, non-steroidal anti-inflammatory drug hydroxychloroquine, sudden withdrawal of the systemic corticosteroids, and lithium. These are the drugs which can exacerbate the disease. Just you have to remember some medications which can exacerbate the disease, and some metabolic factor like calcium deficiencies and hormonal factor and smoking and heavy alcohol consumption, these also can exacerbate the disease. So, some environmental factor, some infections, medications, skin injury, these are factors which can exacerbate the disease. Just remember some important triggering factors like infection, that is streptococcal infection and viral infection, skin trauma or skin injury, stress, drugs, metabolic factor like calcium deficiency, hormonal factor, and the smoking and heavy alcohol consumption, all are important triggering factors which can exacerbate the disease. Now coming to the role of T cell. The T cell plays a very crucial role in the development of the disease. As I have already told, there is a genetic factor, environmental factor, and immunological factor. All together plays a very crucial role in the development of the disease. How it occurs? Particularly the current hypothesis says that unknown skin antigen, if this unknown skin antigen may be some medications, maybe some infection, streptococcal infection or viral infection, which can stimulate the immune response. And antigen specific memory T cell are the primary mediators of the disease. Antigen specific memory T cell are the primary mediators of the disease, and all this lead to the impaired differentiation and the hyperproliferation of the keratinocyte, and in that case keratinocyte proliferates 6 to 9 times than the normal, 6 to 9 times faster than the normal rates. So, how it occurs? As you know, any types of the environmental triggering factor, say for example that is streptococcal infection or any viral infection or some streptococcal superantigen, whenever it exacerbates the disease in a particular genetically susceptible individual, in that case it usually activating the immunogenic T cell. In the epidermis, usually the upper layer of the skin, that is, you know, that is epidermis, the CD8 T cells are most commonly found, and in the dermis the CD4 cells are predominantly found. And whenever any triggering factors are found in a genetically susceptible individual, it is stimulating the CD8 plus T cell, and when the CD8 plus T cell stimulates, it produces the TH1 mediated response, and this TH1 mediated response produces some cytokines and interleukins, particularly interleukin 2, interleukin 6, interleukin 8, interleukin 12, TNF alpha and gamma interferons, and all this together plays a pivotal role in the development of the disease. And particularly the TNF alpha again stimulating the keratinocyte to produces the interleukin 8, and interleukin 8 is a very important chemoattracting factor for the neutrophils, and as a result of this there is the accumulation of the neutrophil occur in the epidermis, leading to microabscess formation, and all these cytokines and the chemokines usually causes the differentiation and the hyperproliferation of the keratinocyte. As a result of this, there is the excessive proliferation of the keratinocytes occur. So, it grows faster, comparatively 6 to 9 times faster than the normal rate, leading to the development of the thick psoriatic plaques. So, most important immunological factor is the any types of triggering factors. When it occurs in a particularly genetically susceptible individuals, it produces it stimulating the CD8 cell in the epidermis, which usually produces the TH1 response, and when the TH1 response, when the T lymphocytes are stimulated, it produces some important cytokines and interleukin. Most important is the interleukin 2, interleukin 6, interleukin 8, interleukin 12, TNF alpha and gamma interferon, and all these things together causes the hyperproliferation of the keratinocyte and leading to the formation of the thick psoriatic plaques. These are usually most common hypotheses or most common factors of pathogenesis of the disease. So, now coming to the next slide, that is the clinical features, which is very important. How it presents, that clinical feature, that means the both signs and symptoms. Pruritus is the hallmark of the disease. Pruritus means the patient will complaining of extensive itching. The psora means, the word psora means itching. The patient will complaining the extensive itching. And how it looks like, this is very important. The primary skin lesions are well defined, round, erythematous scaly papules and plaque, usually distributed over the extensor aspect of the body, that is elbow joint, knee, front of the leg, scalp, sacral region, or any site of the body can be involved. So, most common sites are the erythematous scaly plaques, which are distributed over the most commonly in the bilaterally symmetrical over the elbows, knee, front of the leg, scalp or the sacral regions are usually found. Number 1, with lesions are usually scaly. How the scale looks like? The scales are micaceous, meaning they peel in layers, and they are looser towards the periphery and adherent centrally. When the scales are removed with the help of scalpel or with the help of glass slide, bleeding points appear, which is known as Auspitz sign. So, this is very important, which is Auspitz sign. In a new psoriatic plaque, if you remove the scale with the help of glass slide, you can see the small bleeding point can be seen. This is known as the Auspitz sign, and the test is known as Grattage test, and the test is known as Grattage test. The test is known as Grattage test. So Grattage test is a bedside test. So, if you remove the scales of the psoriasis with the help of a glass slide, you can see the fine bleeding points, which is known as the Auspitz sign, and the test is known as the Grattage test. It occurred due to the loss of plasma membrane or Blacklees membrane or damage to the upper capillary, the upper dermal blood vessels, upper dermal capillaries, leading to the pinpoint bleedings, which is known as the Auspitz sign, and the test is known as Grattage test. Now, coming to the development of psoriasis lesion occurs along the line of trauma. This is known as Koebner phenomenon or isomorphic phenomenon. So, what is Koebner phenomenon? Koebner phenomenon means development of the new skin lesion which is similar to the pre-existing dermatosis both clinically and histopathology, which occurs following trauma, is known as isomorphic phenomenon or Koebner phenomenon. In the psoriasis, suppose a psoriatic skin lesion is present here and there is a minor skin injury or trauma or minor burn injury, it produces the development of the new psoriatic lesion along the line of trauma. This is known as the isomorphic phenomenon or Koebner phenomenon. It is found nearly 25% of the psoriatic patient, and it usually takes approximately 7 to 14 days to develop, and this is the most important thing you have to remember. Now, coming to the nail changes. Psoriasis, as I have already told, not only affecting the skin, but it can also affecting the nail and joints also. The most important nail changes in the psoriasis are found the thimble pitting of the nail. That means small depression, thimble pitting of the nail. Other changes are subungual hyperkeratosis, discoloration of the nail, onycholysis, that means separation of the nail plate from nail bed, and increased chance of development of the bacterial and fungal infection. So, the most important nail changes are the thimble pitting of the nail, subungual hyperkeratosis, distal onycholysis, discoloration of the nail, and increased propensity to develop the bacterial and the fungal infection. Joints can also affecting in the psoriasis, and most common part of the joint affecting the oligoarthritis. That is oligoarthritis with tenosynovitis affecting the hands and feet joint is most common joint affected, and it also produces the deformity of the joint. Now, coming to the types of psoriasis. So, what are the types of psoriasis? Most common type is the chronic plaque psoriasis or plaque psoriasis. Plaque psoriasis is the commonest type which we encountered in our clinical practice, and the other types are that is gutted psoriasis. What it means by gutted psoriasis? Gutted means raindrop like, bishtir photar moto, raindrop like lesion is found. It usually commonly found in the children and the adolescent age group. This is known as the gutted psoriasis, gutted psoriasis. Now, coming to the flexural psoriasis or inverse psoriasis. Psoriasis most commonly found in the extensor aspect of the body, but when it affecting the folds, that means the axillary fold, inframammary fold, gluteal region, it produces, then it is called the flexural psoriasis or inverse variety of the psoriasis. The other varieties are, that is erythrodermic psoriasis, that means diffuse erythema, diffuse redness and scaling affecting more than 90% of the body surface area. Diffuse redness and scaling affecting more than 90% of the body surface area in the psoriasis is known as erythrodermic psoriasis. Pustular psoriasis. Pustular psoriasis is a very important thing, that means the legs of pus are found along the margin or edge of an erythematous plaque is known as pustular psoriasis. It may be localized pustular psoriasis that affect mainly found in the palm or sole, that is localized pustular psoriasis, or generalized pustular psoriasis, also known as von Zumbuck disease, the generalized pustular psoriasis. In that case, you will find the small pustules are found along the margin of an erythematous plaque. This is known as a pustular variety of the psoriasis, and also psoriatic arthritis, and some local varieties are found, that is the palmoplantar psoriasis, psoriasis affecting the palm and joint, nail psoriasis and the scalp psoriasis. These are usually the local variety of the psoriasis. So, you have to remember just think that chronic plaque psoriasis is the most common psoriasis, gutted psoriasis, that is raindrop like, commonly found in the children and the adolescent age group. flexural psoriasis or inverse psoriasis, erythrodermic psoriasis, pustular psoriasis, psoriatic arthritis, local forms, that is palmoplantar, scalp, and the nail involvement. These are the types of disease or psoriasis. Now, these pictures are important. You can see this is the type of plaque psoriasis. This is the localized plaque psoriasis. You can see the localized erythematous scaly micaceous plaque mainly found over the knee joint. This is a type of localized variety of the plaque psoriasis. Okay? This is a case of localized plaque psoriasis. This is generalized plaque psoriasis. You can see the erythematous plaque with scale present almost entire body, most of the body surface area, that is abdomen, chest. You can see in the forearm, arms, and other areas of the body. This is the case of generalized plaque psoriasis. This is the case of generalized plaque psoriasis. Localized means that's localized to the particular area, localized to the elbows or localized to the knee joint. It is a but it is a case of generalized plaque psoriasis. Generalized plaque psoriasis. Now coming to the scalp psoriasis, that is localized form. You can see that erythematous scaly plaque, particularly it crosses the hairline. You can see that it crosses the hairline. It's very important characteristics of scalp psoriasis. You can see that it crosses the hairline. It is a very important feature of the scalp psoriasis. Now coming to the nail involvement. As you can see, the nail psoriasis in nail involvement, that is you can see the small pitting of the nail, small depression can be seen. This is the pitting of the nail. This is the earliest feature of the nail changes, that is thimble pitting of the nail. MCQ day. What is the earliest nail changes in the psoriasis? That is thimble pitting of the nail. Depression less than 1 millimeter. You can see the thimble pitting of the nail. Thimble pitting of the nail. Thimble pitting. You can see the distal onycholysis. Distal onycholysis. That means separation of the nail plate from nail bed. Separation of nail plate from nail bed. This is the distal onycholysis. And you can also see the discoloration of the nail, that is Eolis discoloration of the nail, and also see the psoriatic plaque over the dorsum of the hand. Psoriasis plaque over the dorsum of the hand along with the nail changes. And also there will be discoloration of the nail. So in this picture you can say the pitting of the nail, subungual debris, subungual hyperkeratosis can be seen, subungual debris, subungual hyperkeratosis, and distal onycholysis can be seen. Okay? This is a case of nail psoriasis. Now coming to the palmoplantar psoriasis. When the psoriasis affecting the palm and sole, this is known as the palmoplantar psoriasis. Palmoplantar psoriasis. You can see that there is erythematous scaly plaque, well-demarcated plaque, dry lesion, most commonly found in the palm as well as in the sole. You can see also the fissuring of the soles. This is a very important characteristic feature of the palmoplantar psoriasis. Palmoplantar psoriasis. Now coming to the generalized pustular psoriasis. As I have already told, that in pustular psoriasis you get the legs of pus. Legs of pus usually found around the erythematous plaque. Legs of pus. This is the pus. Legs of pus are found at the margin of the erythematous plaque. At the margin of the erythematous plaque. This is known as the generalized pustular psoriasis. So now coming to the treatment. So diagnosis. How we can diagnose it? Diagnosis mainly by the clinically. Mainly by clinical diagnosis. In the rarest case, you can do by histopathology, but mainly diagnosed by the clinical examination, clinically, number one. That means, whenever you can see the erythematous scaly plaque distributed mainly over the extensor aspect of the bodies, and you can also look for the other sides like the nail changes, like the scalp, and also you can see the palm and sole and the joints. So, most important thing. The medications which are given in the treatment of psoriasis, that is the localized variety of the psoriasis. If the psoriasis is confined to a particular area or less than 10% of the body surface area, in that case the topical medications are given. Most important topical therapy for the psoriasis are the emollient lotions. That is the whites of paraffin, light liquid paraffin lotions are most important. Topical corticosteroid. Topical corticosteroid, usually the potent to superpotent steroids are usually given, and except in the face or the flexural areas, in that case usually we can go the mild potency or mid potent steroid or low potency steroids can be given. Otherwise, the most important is the potent steroids are usually we give. It is given for a once daily basis for 2 weeks, and after that it is given in the weekends basis for long time can be given in the weekends. Now coming to the vitamin D3 analog, also known as the calcipotriol. Vitamin D3 analogs are also very important topical medication we used in the treatment of the psoriasis. Calcipotriol, coal tar. Coal tars can also be used in the psoriasis, but presently it is used for the treatment of the scalp psoriasis. It can also be used in other areas of the bodies also, but the most important thing is the tar has an offensive or pungent odor, and it usually produces the folliculitis type of lesion. Now coming to the diathronol or anthralin. short contact anthalin therapy or SCAT, short contact anthalin therapy can be given for usually 15 to 30 minutes. These are also used for the treatment of the localized variety or localized plaque psoriasis. Calcineurin inhibitors, as you already know, calcineurin inhibitors like tacrolimus ointment or pimecrolimus cream are particularly effective for the treatment of the facial psoriasis and also the flexural variety of the psoriasis, where there is a chance of skin atrophy with steroid. In that case, we will give for the calcineurin inhibitors. Salicylic acid is a very important keratolytic agent used in the treatment, also effective for the treatment of the scalp psoriasis. The shampoo or gel based form can be used, and also salicylic acid can be given for the palm and sole, that is the palmoplantar disease. And topical retinoids, that is tazarotines, can be given along with steroid, and it can be given for the treatment of the nail psoriasis also. Now, coming to the phototherapy. Phototherapy is also effective for the treatments of the psoriasis. The phototherapy which are commonly given for the psoriasis are the broadband UVB, that is 270 to 320 nanometer, narrowband UVB in the wavelength of 311 to 313 nanometer, and the laser narrowband, that is 308 nanometer, and PUVA therapy, that is Soralin with ultraviolet A therapy. Now coming to the systemic therapy. What are the indications for systemic therapy? And ki karone amra systemic therapy debo? When the lesions are extensive, that means when it affecting the more than 10% of the body surface area, pustular psoriasis, psoriatic arthritis, erythrodermic psoriasis, and palmoplantar psoriasis not responding to conservative topical therapy or not responding to the conservative management. In that case, systemic medications are given. So, what are the indications for systemic therapy? That is psoriasis affecting more than 10% of the body surface area, pustular psoriasis, psoriatic arthritis, psoriatic erythroderma, and palmoplantar psoriasis not responding to the conservative treatment. In that case, the systemic therapies are given. So, what are the systemic drugs used in the treatment of the psoriasis? That is non-biologics and biologics, usually classified in the two forms, that is non-biologics and biologics. So, non-biologics drugs are methotrexate. Usually methotrexates are common drug, usually it is an anti-cancer drug, but used in the treatment of the psoriasis in low dose, usually given in a dose of 5 to 7.5 milligram weekly dose in a low starting dose, and methotrexate usually acts as an anti-inflammatory effect in that case of the psoriasis. And the methotrexate usually, just you have to remember the name, in your standard names are sufficient. Just I am telling one or two side effects, but most common side effect of the methotrexate is the myelosuppression, hepatotoxicity. It can increase the liver enzymes, and also it is highly teratogenic drug. That means it should not be given during pregnancy. Teratogenicity means the induction of fetal malformation. So, it should not be given during the pregnancy. So, before starting of the methotrexate, some questions should be asked regarding the CBC. Number 1, whether hemoglobins or other blood parameters are normal or not, liver function test, particularly SGPT. Number 2, number 3, serum creatinine or any types of the infections or tuberculosis should be ruled out, and patients should be asked regarding the pregnancy, because it is a highly teratogenic drug, should not be given during the pregnancy and lactating period. Now, coming to the other medications which are given for the treatment, that is the cyclosporine. Cyclosporine is basically a calcineurin inhibitors which are act by the inhibiting the enzyme, particularly which are act by inhibiting the T lymphocyte production and T lymphocyte mediated interleukin 2 production. So, cyclosporine produces very good result in the plaque psoriasis and other varieties of the psoriasis also, and also the other drugs, that is acetretin. Acetretin is a systemic retinoids drug. You have already read in pharmacology, acetretin systemic retinoids used for the treatment of the pustular psoriasis and other variety of the psoriasis. But the most important side effect of the acetretin is that it is also a hepatotoxic drug, and also it is a teratogenic, highly teratogenic drug. So, it should not be given during the pregnancy or lactation period, number 1. And the other medications which are used for the treatment, a new drug, that is the phosphodiesterase 4 inhibitor, that is apremilast. Apremilast are also effective for the chronic plaque psoriasis and psoriatic arthritis. This is a phosphodiesterase type 4 inhibitor. But the most important side effect of the apremilast is the diarrhea, patla paikana, diarrhea, and other side effects are usually headache and psychological disturbance or depression can occur. Apremilast. And now near drug, that is the genus kinase inhibitor or JAK inhibitor, tofacitinib, which are used for the treatment of the psoriasis. Tofacitinib can also be used in the treatment of the chronic plaque psoriasis and also in the psoriatic arthritis. Tofacitinib can be given, but the most important side effect of the tofacitinib is the dose dependent reduction of the RBC count and neutrophil count. In the long term, usually it produces the high chance of, it is also a immunosuppressive drug, high chance of development of the tuberculosis and also pneumonia and herpes zoster. So, these are the, just you have to remember the name, that is non-biologic, that is methotrexate, cyclosporine, systemic retinoid acetretin, phosphodiesterase 4 inhibitor apremilast, and genus activated kinase inhibitor, that is tofacitinib. These are used for the treatment of the psoriasis, that is systemic medication. Now, coming to the biologics of the biologics. So, what are the biologics used in the treatment of the psoriasis? Biologics basically inhibit the progression of the joint disease in psoriatic arthritis. Biologics is a very good drug for the treatment of the resistant chronic plaque psoriasis and psoriatic arthritis. It prevents the progression of the joint disease in psoriatic arthritis. So, what are the biologics used in the treatment of the psoriasis? Biologics which affecting the pathogenic T cell, that is aliphacept, TNF alpha inhibitor. As you know, the TNF alpha plays a very important role in the pathogenesis of the disease. So, TNF alpha inhibitors like Infliximab, etanercept, Adalimumab, interleukin 12-23 inhibitor, that is Ustekinumab, interleukin 17 inhibitor, that is Secukinumab, Brodalumab and Ixekizumab. These are biologics which are used in the treatment of the psoriasis. Just you can remember one or two names, that is Infliximab, etanercept, that is sufficient, and the biologics which are used for the treatment of the psoriasis. So, if you can write the treatment of the psoriasis, you can write in short, that is just auto number topical therapy, just important topical drug, that is topical steroid, topical vitamin D analog, calcipotriol, coal tar, anthranil, salicylic acid, topical calcineurin inhibitor like tacrolimus, topical retinoids, phototherapy and systemic drug, non-biologic, biologics. Non-biologics, methotrexate, cyclosporin, acetretin, apremilast, etc. and biologic, infliximab, etanercept. Just you can write this also. This is the usually this is. And what are the comorbidities associated with the psoriasis? What are the comorbidities? Most important is the psoriatic arthritis, which causes the deformity of the joint. Number 2 is the association with other autoimmune disease, that is Crohn's disease and ulcerative colitis, and also the metabolic syndrome. Psoriasis associated with metabolic syndrome like obesity, hypertension, impaired glucose tolerance, hypertriglyceridemia or hyperlipidemia, and all this lead to the increased risk of cardiovascular disease, and also the melanoma and the non-melanoma skin cancer, and also there is depression and the other psychological aspects can occur. So, these are the comorbidities. These are comorbidities which can occur with the disease. Number, so this you can just remember, but don't remember, it is okay. Thank you. So, these are the, so if you given the short note in the psoriasis, just like এত কিছু লেখার তো দরকার নেই, জাস্ট পড়ানোর জন্য বললাম, what is psoriasis, you write just what is psoriasis. It is a chronic, recurrent, inflammatory skin condition with variable clinical heterogeneity affecting 2% of the population. It is occurred due to the genetic, environment, immunological factor. The several genes are associated with the disease, but the most important is the SORA1 gene, which is present in the short arm of the chromosome 6, is the most important gene associated with the disease. Just then write the clinical features. What are the clinical features? That is erythematous scaly plaque, mainly distributed over the extensor aspect of the body, that is elbow joint, knee joint, front of the leg, scalp or other body surface area with micaceous scale. When the scales are removed gently, the fine bleeding point can be seen, which is known as the Auspitz sign. The disease develops along the line of trauma known as Koebner Phenomenon. Pruritus is the hallmark of the disease. It can affecting the nail and the joint involvement. Nail involvements are pitting of the nail, subungual hyperkeratosis and distal onycholysis can occur. Now, write the types of psoriasis, that is plaque psoriasis, gutted psoriasis, flexural psoriasis, erythrodermic psoriasis, psoriatic arthritis, pustular psoriasis and localized variety, that is the palmoplantar psoriasis, scalp and nail involvement. And treatment, just like the treatment, that is topical therapy for localized disease, phototherapy and systemic therapy, that is non-biologics and biologics. This, if you write this, this is enough for you. So, just like the definition, genetic, why it occurs, that is complex interaction between the genetic, environmental, immunological factor, the gene which is responsible. Just write the clinical picture in short, types of psoriasis and treatment. This is enough for your, if you given the short note. Okay.